Mhm.
Welcome to the Zoom meeting. This is my friend Dr. Devraj from New York. He's a pediatric neurologist basically, but he's posted in the COVID-only hospital during this the infection time. And I don't want to waste time further. I switch over to Dr. Devraj. Devraj, we are very happy that you're here and going to give us a lot of information about the COVID through your experience, what you went through the last 2 weeks. Thank you so much.
Thank you, Dr. Ram, for introducing myself. My name is Devraj Chowda. I'm doing pediatric neurology, and recently, because of this COVID pandemic, I was redeployed to medicine department, and especially the ICU, for management of the COVID patients. Uh, so before talking about the COVID, and as like I've been through a lot with because of the COVID in entire New York, and especially our hospital because it was in a state hospital, so it's declared as a COVID only hospital. Uh, before starting, I'll go with the little bit word about the COVID-19 virus. It's one of the coronavirus is a well-known virus, which basically commonly calls common cold. And but this specific strain of the RNA virus COVID-19, it's found in the bat, which also get infected by the similar kind of strain. And it has a unique features of affecting most likely the lower respiratory tract, which is basically your lungs. Lungs are your lower respiratory tract, and it's primarily affected by this COVID-19. When talk about the further, what are the people who primarily get affected with COVID-19? Usually, what we see that people who are aged, like more than 50 or 60 years old. Also, the other high risk group is the patient who has a diabetes or any other chronic conditions like hypertension or kidney failure or any immunocompromised disorders. So that are the things that commonly you found that these people are because their immunity is suppressed, and that's the thing probably they are not able to fight against the COVID. So this particular group of the patient has to be taken care well. When we move forward, I'll talk a little bit more about what are the symptoms and what you be aware. Symptoms are pretty much common as what the other flu-like symptoms. You have fever, you can have sore throat, you can have a cough, and also body ache, malaise, headache. It's very non-specific. One of the common things with the apart from flu-like symptoms that I recently found that so many patients were complaining loss of taste and loss of sense. Like they don't have like a taste, they lost the sense for like their nose. There are the like two things that I found which is was usually like not present with other type of viruses. uh, that's a common clinical scenario you will see, and there are labs available now because of the PCR testing. We can confirm it, which is almost like 99%. So when you come to the labs, initially when we started the patient seeing with the COVID-19, we didn't have the PCR, and PCR used to take like 3-4 days. I don't know about the current situation in India, but here in United States, initially it was very hard to get a PCR testing. So we started doing some certain amount of the labs, which can help you to say whether the patient is likely, what like the likelihood of patient having a COVID. So we started doing ESR.
Yeah, in India now it is from 4 hours to 24 hours max it takes, but within 24 hours they give you the test.
That's really good. That's one of the thing that kind of very helpful. Right. We have a testing. We did like a ESR, CRP, ferritin, and D dimers. They're super high when patient has COVID-19. It's very high risk. Like if you have COVID-19 with the severe form of the disease, then you can have this biomarker is going to be high, and that's also be kind of trending towards like. And at the end of the course, it gets better. Apart from antigen antibody testing, as sir mentioned that you guys have PCR now, which is available within 4 to 24 hours. That's great. Now recently people are talking about antibody testing, which is still in the trial. There's 6 different companies sponsoring that, and to be honest, it's not that reliable yet. So antibody testing are still in the once all the studies come up, then you can say what are the specific uh, the requirement, like false positive, false negative in the term of statistics. The thing is the reliability in the common word of the antibody testing is still not well established. Antigen testing is well established, so it's really important. um, Other thing is that I want to mention about the testing part, that testing is one of the things that everyone is keep, like, everyone has a concern that when to get testing, when not to get testing is really important. I don't think so that everyone needs to get tested, first of all, because at the end it's just a taste, and the most of time the clinical scenario is very important. Second thing, which groups are needs to get tested. So patient who has the symptoms, like as I mentioned, like runny nose, has a sore throat, has a fever, has a headache, you can get tested, and then you can know that if you are positive, then you are likelihood that you also infected the person who are in contact with you, because the incubation period for this virus is 1 or 2 hours to 2 weeks. So within the 2 weeks of the period, if you were in a contact with any of your relatives, any of your colleagues, that's most likely that you got a uh, you gave them the infection. So that's the one thing. Second thing, that how you spread that infection. So this is a droplet infection and also the contact. So whatever you, if you touch something, so that's with your hands, or especially this phone, like you touch this phone all the time, and then this is I guess this is one of the most highly infectious, contagious disease, uh, and this is always caused by this phone is the one of the most common thing, I would say. And with the droplets, so someone sneeze and someone cough, so that's why it's very important to wear a gloves and to wear a mask. And that's something, the thing that you can prevent the disease at this point, because as we know that there is no proven study so far that for the treatment of the disease. So the all thing you can do is to prevent. uh, yeah, so further, before going further, I guess if Dr. Ram has any further question between that.
Yeah, it's perfectly fine. But the pediatric age group, because the schools are going to open here soon, and we don't have a clear idea how is the symptoms for the pediatric age group is different from the adult age group, or the precautions what the kids has to follow when they're going to the school. I do understand the mask and the, yeah, the protective measures. They have to follow the
Right.
alcohol, sanitation, the rubs and other things that are not common. But anything special you want to mention here about the pediatric age group? Anything special?
So the pediatric age group, there, like, first of all, we were so lucky that the pediatric age group has very low risk of having a disease. Somehow their immunity was great, or what exactly works, we don't know. But then we didn't have much pediatric patients admitted with COVID-19, and in my hospital there was not a single death from COVID-19 from pediatric age group. Definitely there was like so many people from the adult age group, but the pediatric age group. But recently we are getting the patients with the multi-system inflammatory disorders in the pediatric age group, where the patient has a Kawasaki-like disease, where it's basically affecting every system. And but this is also one of the rare conditions. It's like very, like, we see probably like a 1% of the population. So luckily, the pediatric age group is spared from the severity of the disease. But other side is they are the main carriers, because they play around, they touch the things, so they are actually very high risk group for the older people. If you are in the same household with the someone with a 70-year-old and someone is a 5-year-old, this 5-year-old gonna get a infection and gonna spread to this 70-year-old. They're very high risk of chances. Now when you go back to the school, or any other, I would say, like in general, any other employment, whenever you start, the social distancing is the most important thing. First of all, you can do like a 6 feet apart. And to do that, to order to do that, I know that India is a little bit like, it's one of the largest country, and it's very hard to do social distancing. But then maybe the school can be like start like in the different schedules, like someone between 7 to 11, and then 12 to 5. So the timing can be changed, and then the timing can help, because then it minimizes the exposure of the people with each other. The second thing is that prevention of this mask. The mask will actually help not to get infected, but to help to spread the infection to someone else. Frequent hand washing. Kids are very well known that they just like play and then put something in the mouth. So it's very important that encourage kids to do a frequent hand washing, and by all means, whatever you do, to understand for the kids to what is the severity of the disease is very hard. So we have to be a little bit more precautious when we come to the child. But it's also not nice to keep the child at home and just for 2 or 3 months because it's something come up with other problems.
Yeah, I think the schools initially when they're starting, they have to take classes about these COVID issues a lot. I
Hmm.
think the kid
Hmm.
understand why they have to follow all those things before they start the real class. I think they have to keep emphasizing this every day before they start the class. I think that would be the better than, because kids they listen to the teachers than the parents. You understand? So again, let them teachers has to emphasize. So the teachers has to be taught the proper precaution by the medical authorities before they start the schools. I think that every school has to conduct some the discussion from the medical personnel so that they also educate the teachers a lot. I think that will be another way to manage it. Yeah, yeah, come on.
I completely agree with sir. Like that's kids follow the role models, and their role models are usually teacher, not their parents. So yeah, whoever they follow, if that person tells the kids, they're gonna follow the same thing. And yeah, I completely agree that what exactly you mentioned, that someone teacher kind of role model, if
Yeah,
he emphasizes, then the
one
kid's
more
gonna
thing,
follow it.
when the results comes positive, whether they have to go and get admitted in the hospital, or yeah, they have to isolate
Right.
themselves if there is no
So
symptom.
that's a really good question. And actually, if someone has a symptom saying that what are the type of the severity of the disease, mild, moderate, or severe? So, person who has a mild disease, which means patient has someone like a fever, runny nose, but able to breathe. There is no hypoxia. Hypoxia means there is oxygen saturation is good in the blood. They don't need to get admitted. It's better to stay at home, because if you go to the hospital, there are high chances you're going to get another infections, because the COVID is high risk for doing a lymphopenia. So your immunity going to go down with COVID, and you're going to get another infections from the hospital. So that's the one thing. The second thing is that you're going to spread more infection to the other people. So it's better to stay at home when you have a milder form of the symptoms. But when you are at home, certain precautionary measures you have to take. You have to keep yourself isolated from other members of the family. I guess I would encourage other members to go and get tested. If they are asymptomatic, if they don't want to get tested, that's fine, but they have to quarantine for 14 days at least. And that's, I guess, the most important thing. If you have moderate or severe symptoms, moderate is shortness of breath, and severe is when you have a respiratory failure. You can't breathe it by your own at all. Severe patients needs to be admitted to ICU, while the someone with the moderate symptom where has shortness of breath require a inpatient admission, not an ICU, but at least somewhere where you can monitor the patient.
Hey, you carry on with your next thing.
Mhm. Okay, so that's how we divide the patients. Now, so in my experience, or in general, whatever the data available so far, what we have, most of the patients who are 80% of the patients who are positive with uh, this testing and confirm COVID-19, they're able to stay home, and we are able to manage them at home. They do not need to come to the hospital. By televisit, like a Zoom, you can call. They usually call the doctors, and they give advice, and they stay home, and what are the things they can do. 20% of the people who get admitted, out of that, only 5% of the people require ICU. Only 5%. So out of 180 goes to the home, 20 stay in the hospital, and out of 20, only 5% people stay in the ICU. Out of that 5% ICU, there are like 1 or 2% mortality. So if you look at overall this disease, like there's so many people who doesn't have a symptoms, which we don't even know. That probably there are like so many people there who doesn't have a symptoms. Then out of that patient who develop the symptoms, 80% can able to stay home. Out of 80%, 15% are just on the ward. We're just for the management of like just something like maybe require a little bit of oxygen. So if you look at overall, this disease is not that bad. If you want to go like a by statistic wise, so only people who are get admitted to the hospital, majority of them are what were older, who already have another chronic conditions. and this one more hit, they can't take it, and that's why they are in ICU. They already have COPD, their lungs are already damaged. Now this one more thing, it's gonna break it. So that's very important thing to keep in mind. Like, do not scare of this disease, because the scare is like, you have to take precautionary measures, but it's not that dangerous. What you like, you got a COVID and you're done. It's not like that. There's very like 1% chance that you can end up in the ICU. On other hand, India and US, it's very hard to compare, because India has a different geographical distribution, plus immunity. Everything is different. Here we have majority of the people who are older. They're more than 60, more than 70, 80, or 90 or 100. In India, you rarely see someone more than 60 or 70 years old. So majority of our patients have uh, comorbidities. They already have diabetes, HIV, and other diseases. So our patient population in general is more vulnerable than India itself. So that way, maybe the another reason that why India is not that much affected compared to the United States. uh, Now, when you come to the treatment part, the ward management is just to manage something what you usually do in the ward, like manage the oxygen. It's more like a symptomatic management, or fever management with Tylenol or anything.
You see, if you
When you
want,
come,
sorry,
hmm,
sorry to interrupt. See, the
sure.
mild to moderate symptom patients, like the mild patients, they are going to stay at home. Uh, Only the symptomatic, say, example, they have fever, they're taking paracetamol. Or do you want to help them with something like a multivitamin or any other things they have to take for the increasing the immunity or something?
So yeah, multivitamin, of course, is going to help you with the oral, to build up your immunity, and like to for the more energy. One thing is that patient who are COVID positive and has a mild symptoms at home, we recommend azithromycin.
Okay.
There are two reasons. There are some studies shows preclinical data that it can be useful, but other than that, also that it prevents the secondary pneumonia, and that's the primary reason why we give the azithromycin for the patient with the uh,
Mild disease.
mild symptoms. Right.
Moderate, they are going
Uh,
to the hospital and they are going to manage at the hospital level. This is for the doctors. It's a moderate patient. What is the line of management in the hospitals in US? What you guys follow?
so, as I mentioned, moderate symptoms, which require basically you need some kind of support, which means you need some oxygen through the nasal cannula. And that time we manage them on the floor. We do the cardiopulmonary monitoring. We do like basic labs like CBC, CMP, and we also give azithromycin and HCQs. Especially, we all know that azithromycin and HCQs. I'm sorry, just to mention, HCQ is hydroxychloroquine. Hydroxychloroquine and azithromycin, when you combine, it can cause prolonged QT or arrhythmia. So we do Q every 48 hours EKG. Uh, Whether it's help, whether it doesn't help, it's still under the study. Recently, from the one of the best institute in Michigan, it's Henry Ford Medical Center. They say that when you give HCQ to the patient when they're inpatient, and their increased requirement of the respiratory support. So it doesn't even HCQ does not support the COVID-19 at that point. So that's something still in the process. But we are also the part of clinical trials, so we are giving HCQ, and some patients are without HCQ. Our results are still not out yet. So we'll see how it affect for the moderate patient for HCQ plus azithromycin. So this is about moderate symptoms, which is okay. I mean, you give this, you don't give this, you give oxygen, and most of these people are young, so their lungs are good, and then get out of this and they go home. Usually with the asthma, or they have a COPD, and then you treat that primary disease as well when you are treating with COVID-19, and they get better. Uh, when you go for next is the severe symptoms. Severe symptoms mean a hypoxic respiratory failure. You are not able to maintain your oxygenation just with the nasal cannula. You're really requiring high volume of oxygen, and you're requiring your respiratory support. And that's the patients who require the ICU monitoring. In ICQ, our hospital was like is a COVID only hospital, so it's involved in a lot of clinical trials. So we actually did tons of things. We throw everything, whatever we have at this point. Even the small preclinical data shows some evidence. We started using that. So what I usually like, we use is high dose methylpred. It's like a 1 gram every day for like 3 days in a row, or 5 days, depend. If there's a COPD, go for 5 or 6 days, and then taper slowly. The other thing is that all these patients has a very high, sorry,
The drug name, what you have mentioned, I didn't get the drug name.
it's a methylprednisolone. It's a
Okay.
steroid,
Okay.
solumedrol.
Okay.
Yeah. So that's steroid.
Okay.
Second thing is that all the patients has a very high D dimer. So we think there is some procoagulant effect there. Though there is a risk of stroke is decreased with COVID-19, but whatever the clot formation is really big. So we think it could be the another procoagulant thing, and we started all the patients on a high dose anticoagulant. It's a Livernox at therapeutic level. The second thing is antiviral. So there are different studies like lipinavir, basically all the protease inhibitors. The different protease inhibitors were tried. So far, none of them shows any clear-cut benefits. And especially, we all know that protease inhibitors has a problem with the kidney failure. And it's one of the very important things to keep in mind when the patient comes to ICU. I see most of the patient has acute kidney failure. When patient has a kidney failure and respiratory failure both, the risk of death is more than 80%. And these are the conditions where you need to treat with the all whatever the options you have. We have like a majority of more than 50% of the patients in ICU had a kidney failure. Kidney failure and respiratory failure, these are two conditions. And that's why the patient with the kidney failure, they are one of the very high risk population for the COVID-19. We throw them convalescent plasma, and people who doesn't know about convalescent plasma, that's a very old technique that used in when there was a flu pandemic in the back, like how many years I don't know, but in the back they used it. This convalescent plasma is basically antibody, someone who got infected and got recovered. Now they develop the antibody, and this antibody you can use for the person who are currently infected to help them. And actually that's also one of the promising thing compared to any of the whatever I see so far. Steroid and convalescent plasma, they're one of the, I guess, upcoming therapy for the COVID-19, and that can have more effect. I cannot say certainly at this point because I do not have a statistical data, whatever the observation I have from my own ICU experience. But soon, within 1 or 2 months, we'll get the results, because situation is calm down, and then we gonna publish the paper soon. So that's, I guess, more about the severe disease. So Dr. Ram has any other questions for the severe disease or anything?
The thing is, now the problem is when to start our surgical practices, semi-elective, and completely elective surgery like cosmetic surgeries. And one more thing, like about the healthcare workers, they're going to go to the ICUs. You're with ICUs, but before anything, I want you to tell about your last 2 months, 3 months experience when you're working within these wards, and about your experience, because that matters a lot to the healthcare workers who are afraid to go to the ICU, who are afraid to enter into the theater. I think that your information will be very valuable to us.
Thank you so much. Sure, I would love to share my own experience. So the first question was that for the elective surgery, we restarted our elective surgery for which based on the priorities, like someone with the orthopedic knee surgery, which is more than other orthopedic surgery. We're like, okay, let's start that one. So what we are doing at this point, that within that week, if the person has this week scheduled surgery, we do the testing that week, and even if they're asymptomatic. If the testing is negative, they're clear for the surgery, and then they do not test any other person, just the person himself, and also the doctors and all the healthcare employees, they also get tested. To be honest, testing by healthcare workers, that doesn't mean that you're gonna stop using prophylaxis. Prophylaxis saying like hand gloves, wearing a mask, and all this thing. So testing shouldn't change for healthcare workers. Getting tested, getting not tested does not make any difference, because they still have to take the same precautionary measures. And the one thing you have to keep in your mind, that you get tested, you got negative, you're fine. No, because second day you can get another infection because you are working in such a high risk area. So testing for employees, it's, from in my sense, it's not the big thing, because you can get test positive, negative, you still have to use the precautionary measures. Important thing to know that how this infection spread for employees, that it's primarily contact and droplet, unless you do intubation. So when someone needs for this elective procedures, when they go for general anesthesia, they need a intubation, and that point you need airborne precautions like N95 mask. Otherwise, I did work in ICU just with my regular mask, like a surgical mask, and I'm fine. I didn't get any symptoms so far. Neither my friend. We all worked with the proper, you gown, you have a gloves, you wear a face shield, and you have a mask, and that's sufficient. Thing is that you stop touching your face. Everyone has a temptation to touch face, so that's the one thing. And all employees, like our, like, people who get tested, some people are positive, some people are negative, but it does not change the way they react. Like, even people who are positive, it doesn't have a symptom, they still come to the work. And people who are negative, they still come to work. And some my employees got admitted to the hospital, they recover, and they're again back to the hospital. So it's not something that I would really say that it changed whether you gonna get tested or not for employee. Now, when you come to the patients, when you do elective surgery, the two things, like elective surgery should be start first with the anesthesia, like a lumbar puncture, like through the epidural. That would be the first preference. And if you go further, then you go for the procedures which require intubation. So that's how we are starting right now. But we already started our elective procedures. We can't just set, like, as you all know, that New York is a very high risk area, but it has been a 2 months and we are seeing good things now. So there's like a famous thing we always say, that we learn new things from from the past. The experience teaches. As we all know that China and Italy, they are getting better. The same way, US started around March and it's 2 to 3 months now, so which is the May, end of the May, we already started our elective stuff. In hospital where we had 100% patients with COVID, now we have only one third of the patients with COVID. Two-thirds of the patients are non-COVID patients now. So things are getting better in 2 to 3 months, and that's what exactly I assume. When the India, it started around the same time, around March or April, and it should get better soon. Um, right.
We spoke about the pregnancy and that, like the pregnant woman going for a delivery. What is the protocol followed there in US?
So initially it was very like scared, because we don't know what it is. So every pregnant woman got tested. But when we see later part of the course now, there is no change in outcome if the pregnant woman get tested or if pregnant woman not get tested. Even if they're positive, they are negative, it does not change the outcome of delivery. So it's something it's the if you do statistical analysis, patients who are pregnant and patients who are not pregnant, they get COVID, they have similar symptoms. It doesn't Pregnancy does not affect the uh, outcome of delivery. The now thing is, the only thing is that when you deliver the baby, so the most common question comes, how to breastfeed the child. And that is one of the major concern for all the moms who are COVID positive. So that time what we do, if we also test the baby with the COVID-19, same nasopharyngeal testing. And if baby is positive, then baby can go to the mom and have a breastfeeding, doesn't really matter. But if the baby is negative and mom is positive, the mom has to do a face mask, clean the breast and nipples, and then she can breastfeed the child, or she can pump the milk and give it to the child. But the breast milk is not contraindicated because of COVID-19.
Very good information. In fact, this is very confusing for a lot of the orthopedic obstetrician here. So I think your information is really valuable.
Thank you so much. So that's something important. Other thing is that a lot of people also ask that apart from this protective PPE, is there any medication which helpful for prevent the disease for a health worker? I know that government of India started HCQ for the all healthcare workers. Whether it works, whether not works, there is some theory behind that. Like there is some logic behind it. It's not something that without logic, but it's without evidence. As we, after coming here, the most of medicine we believe is evidence-based medicine, and we don't have any evidence yet. But very soon, Henry Ford Medical Center had a 3,000 employees. Out of the 1,200 employees offered to get an HCQ for like there's a 1,200 healthcare worker who got the HCQ, and their study will come by the beginning of the June, and that will be the biggest data so far whether HCQ works or not for prevention of the disease. So far, I don't have any clinical data for that. So that's about that. Also the testing part, a lot of people comes and like ask about the testing, whether they are positive, once they become positive, when they gonna become negative. So the very important thing uh, to understand what is how you taste this thing. So the tasting part is that you take a sample from your nose and you go all the way to the pharynx. So it's a nasopharyngeal sample. You take the sample through the swab, and then you go for PCR testing. The PCR basically check some part of the virus. So important thing to understand this, why I explain what we do for testing, that there is sampling error. Sometimes you take the swab, you may not go all the way to the pharynx. So you do not have a good sample. So which can result into the false negative test. Second thing is that you got a disease, you got better, you are recovered. Now you go for testing again and you're still positive. Why? So the question why is because the patient, this what we test is a virus product. So virus can be inactive at that time. You are recovered. Your virus is, you are completely fine. Your virus is inactive. Virus cannot infect anymore. But that particles are still in your pharynx, and that comes positive. So your PCR testing positive, it doesn't mean that you have infection at that time. You just because you had an infection, it's a dead virus staying in your body. So yeah, that's something very important about the testing part. And antibody, as I mentioned, it's still in the process. I got my own antibody testing,
Okay.
and it's something I guess still in the process.
Okay. What is the protocol? Say, example, if the guys become positive, COVID,
Mhm.
that PCR test is positive, how frequently they have to check for the PCR after the infection, or any protocol, any kind of method followed in US?
Sure. So there are two things that we follow. Uh, Depend, as I mentioned, someone with a high clinical suspicions. Like you come to the test, you come to the admit the patient. Patient is in ICU. Patient has a severe hypoxic respiratory failure. As I mentioned, that labs initially, D-dimer, ESR, CRP, everything is high, but your PCR testing is negative. So you kind of wonder how can it be possible. So in initial phase of the period, you may have a negative result. So you have to repeat that test, especially when your ESR, ferritin, CRP, and D-dimer is very high, and then repeat testing. So you do twice for the patient who has very high clinical suspicious. Patient who doesn't have a high clinical suspicious, has a mild symptoms, you do not need to repeat the test because it's very confirmatory test. Only patients who have very high suspicious. Now, someone who got admitted, had a PCR, he got better, he got recovered at home, you do not need to test the patient. That's completely waste of the money
Yeah,
because, as
because
I mentioned.
what they are doing nowadays is, in India, what they are doing now is, if, even the younger guys, when they are positive, they'll take them to the hospitals. Like, because
Mhm.
now we have a less volume, they are wanting to protect the community from spreading the infection. So they take them
Right.
to the hospital. They periodically test for this. I don't think it is required, because if there is asymptomatic, let them keep them for 2 weeks and they can send them back without doing any test. There's no point in doing a test. If the negative,
Right.
even after 2 weeks, if it is negative, doesn't mean anything. Even if it is positive, doesn't mean anything.
Exactly, because it can be just a dead virus.
Yeah, dead virus.
So that's something we don't do here, unless they have symptoms again, and then you want to test again. That's something different story. Because there's always a chance that you can get a reinfection. So always precautionary measure, no matter what.
That's correct. Actually, one more thing, as you said, in India, most of the patients who are becoming positive are very younger crowd. Like 30s, 40s. Like older patients getting affected is extremely less. As you said, that population itself, the older populations are less in India. Obviously, that might be one reason. And as you know, that immunity-wise, although Indians have a very good immunity compared to the rest of the world, because we all exposed to the infection every other day. So immunity level also high. 90% of the people who are worried about the COVID, the whomever I'm knowing, they are all very young, they're positive, but no symptoms. Okay, that's a common thing what we see here. So it's very informative. Anything else we left discussing whatever we discussed prior to the meeting?
Mm, I guess that's pretty much. Also, we are kind of doing this employee
Anesthetists had
work hour restrictions.
Yeah, my anesthetists have a question for you. The people going for the ventilator support,
Mhm.
how they behave, how they are different from other patients going for same issues, their respiratory failure going for the ventilator, and the COVID patients respiratory failure going for the ventilator. Are you seeing any difference in the response of the patients?
So the course of the disease once the ventilator, it's something that really actually not good with the COVID. That's what I feel. Patient who goes with the intubation, there are patients who comes out of but the if the longer the course, the bad the outcome. If the someone who is like intubated for like 10 days, that has a bad outcome. Someone with a shorter duration, like who went in and then 2 days he came back, that's it. If he doesn't come back after like a week or 2 weeks, and that's something, the protected course is the one that doesn't favor the favorable prognosis.
But there is no other that the response wise both respond same way to the ventilator in the sense initially there is I read some few that because the lung is not expanding at all, it's not like a routine respiratory failure what we have seen, some kind of
Mhm.
information I'm reading somewhere. Is it true, or you have seen anything different?
No, I guess that's something pretty much the same with the other diseases. That's nothing that, especially when you have pre-existing condition with the lung, then of course you're going to have a bad outcome. But
Okay.
other than that, also there is another mechanism like a pulmonary embolism. That's also with a high because of the high coagulation factors.
Oh,
So
okay.
that's something which is usually not mentioned anywhere, but that's what we are observing as well because of the clot formation, and that's something hydrotherapeutic anticoagulation going to help because some patients are dying like quick, and that's something either cardiac or either PE can explain.
Other things, so I'm so surprised to hear that you was told that one third only now the COVID positive patients and other two-third are normal patients. Do you have any, like the boundaries or the COVID patients are separate and there is separate wards for this? Like that, do you have any kind of system now?
So as we our initially was our COVID only hospital, we have 20 COVID team. So COVID 1 team, COVID 2 admission, COVID 3 team, like that. Now we have then slowly as the admission kind of rate went down, so we made a separate floor for the COVID, and the COVID patient goes only to the COVID part only. The rest of the patients stay into the regular floor. It depends on the hospital capacity, like what capacity, but does not require, like initially when beginning there was few patients, we had a patient next this room and the next room has a normal patients. So I don't think so it require a special if the hospital is small setting, but if you're bigger setting, it has to start early in the phase that you can do the separate floor or separate unit for the COVID only.
It's always better.
Right. If you have a facility, sure.
Yeah, I think most of the things we covered, and it's really actually I was so much information in my head. I'm so clear about how to go about, and what do you feel how this course going to be? How long this issue is going to
As
be?
I mentioned before that we learn from our past. So the past with China, Italy, and US is 2 to 3 months. So the India will be out in 2 months. That's what I assume from the past.
But
The
most of
future
the
you predict from the past.
I know. The most of the public's only the thoughts in their mind is how long I need to wear a mask, how long I need to wear all those precautions. Is it 1 month or two
Oh
months?
yeah, so that's very good question. So the virus is in the air now. It's not going to disappear that soon. It's going to be there for a long time now. So the precautionary measure has to be taken for a while, and it can have another season in like in October, November. So at least just like a flu got a season, that I am thinking that in the future we're going to have COVID season.
So second,
And
they
a
say
lot of people still dying from the flu. That's another important thing actually you bring up, that still I see the death from the flu here in US. So I guess that way the people will take precautionary measure for longer duration, and that will help with other infection as well in general.
so clear you are, because even a lot of people, they are predicting that there will be a second wave for sure. So there is no
Right.
point just going and doing normal things. You have to do the precaution. We don't know 3 months or 6 months or 1 year till the
Mhm.
vaccine comes. We have to do the precaution. That's the end message, right? If I'm not wrong,
Right.
correct.
Right, agree. Up to the vaccine, that. But as I mentioned, things are getting better. We are like now working with the normal patients, doing elective surgeries, doing elective procedures. Like I'm in neurology, so I'm doing EEGs now. So things are getting more like a normal. Of course, with the precautionary measures, you have to still take a precautions. And as sir mentioned, with the vaccine, like it's a future hope. Once we have vaccine, and hopefully soon, I guess it will highly impact the outcome of the disease.
Thank you so much, Dave. And actually, a lot of things are clear, even for me. Like I was so confused. Your whole discussion is really useful for me as well as for all the colleagues here, and doctors.
That's
So much benefit as well as the public. Uh, I use this video in YouTube with your permission, and so that
sure.
all Indians will get benefited. Thank you so much. Stay
No,
safe.
thank you so much. Thank you
And
so much for the
we'll
opportunity.
meet you soon in New York. My always dream place. I know I met you in New York last time, and we'll catch up for sure next time very soon. Okay.
Yeah, I am waiting. I mean, I'm not inviting anyone for the New York at this point, but sure, with the social distancing.
I know. Okay. Have a good day. Faraz, good night for you. Good day.
It's a good day and good night for you, I guess.
Okay, Dave. Thank you.
Thank you so much, sir.